And at that point, I realized how much had happened since I had last learned about implant dentistry, and so I decided to go a full force back into school at the University of Southern California to study advanced prosthodontics because I realized when it comes to implant dentistry, I would have to categorize it as prosthodontics. We consider the specialty in as a specialty of replacing missing teeth or ailing teeth, failing teeth. And implant dentistry is pretty much that, replacing ailing and failing teeth. So this is the clinic where I work. This is the Muskegon clinic. I work for the tribal government called the Muskegon Band of the Potawatomi, and they built this community clinic to help people of the community. So I see mostly Medicaid patients and some tribal patients when they're referred to me. As you can see on the bottom left, those are our lab cases any given day. Tons of partials, dentures, sometimes crowns, and so forth. And they built a pretty nice clinic. And what I do day to day is basic prosthodontics, whether it's partials, dentures, implants, your jaw relations, crowns, et cetera, et cetera. I kind of do a balance of fixed and removable prosthodontics in this clinic. And the things I'm able to accomplish are done with a team. And it's because of this team that I'm able to help the patients in my community. I always say that no doctor can do what they do by themselves. And it really does take a group effort. They say teamwork makes the dream work, and these people really make that happen for us. So I just want to jump in and get started with the things that I look at. So the factors that influence restorability for me, you see teeth that are endo-treated, some that are broken, fractured. You know, what do we do? How do we know when it's a good idea to try to do root canals and try to do posts and cores and crowns to save teeth? And how do we know when it's time to just cut our losses short? So some of the factors that I go over myself are looking at the patient's previous history. That can tell you a lot. The remaining tooth structure, that's valuable to know how strong that tooth will be. I look at the crown to root ratio, um, tooth vitality. I look at pathology and carries risk for the patient. Also, I want to consider the periodontal status of the patient, as well as the adjacent dentition, opposing dentition, the position in the arch, whether it's anterior or posterior, the function of the tooth, and the parafunction. So I'm going to stay on this slide for a minute to discuss a few of these things. Crown to root ratio, we know that's important when you're going to consider doing things like posts in the tooth. The shorter the root, the more likely the post length will not be sufficient. So if you're going to assess a tooth with a short root, many times you will see that after someone's had orthodontic treatment. As an adult, you'll see shorter roots, and sometimes it's just not in the patient's best interest to try to keep a tooth that you cannot put a proper post. Another one that I'd like to talk about is adjacent dentition. So why would the teeth next to the tooth that's in question have anything to do with it? Well, what if a tooth may need crown lengthening to be saved? Well, if you're going to do crown lengthening, that will affect the tooth that you're looking at and the two adjacent teeth on either side. So that's something to consider. And well, why would that be important? Well, if you have a tooth with a very shallow furcation and you do some crown lengthening, you may jeopardize having furcation involvement with that adjacent tooth. So that's something to consider. Opposing dentition, well, if you're going to do something with a patient who's going to have an opposing natural tooth versus an opposing implant tooth versus an opposing denture tooth versus an opposing edentulous space, all that will make a difference on the the forces that will be put upon that tooth. Speaking of forces, the position in the arch makes a difference as well. An anterior tooth versus a posterior tooth. We know that our greatest forces are in the posterior on our molars, simply by looking at the size of a molar compared to the size of a central incisor or a lateral incisor. You know right away that one is designed to take on greater occlusal forces, a greater occlusal load than the other. So when you're looking at someone who may have a lot of occlusal forces, maybe someone who has a parafunction like a bruxer, which will take us down to parafunction. Well, if that's the case, the more that may influence the treatment that you do for that tooth, whether it be pulling the tooth or trying to restore it based on the position in the arch. Also, the function of the tooth. A standalone tooth versus a tooth that will be used as an abutment. So as an abutment tooth will have greater forces put upon it. Especially if it's removable, then you'll have forces that go in and out versus a fixed fixed partial denture. So these are just a few things I wanted to just kind of highlight here. So this book here, The Best Practices in Endodontics, a desk reference, has a nice chapter called Evaluating Restorability Prior to Treatment. So even when you're doing endodontics, this is a great workflow, and they've come up with it with their own chart that they recommend going through with the different questions so that they can determine restorability as well. So I personally do a lot of traveling, and I enjoy traveling. I'll put it that way. And then this is the Electric Garden near the Sands Hotel in the background in Singapore. Uh, Beautiful place when lit up at night. So this is case number one. This first patient came to me. She's a 40-year-old female. She said that she started noticing a bump over her tooth in the gums, and she was being a little worried about it. And she wanted to know what could be done for this tooth. Well, you can see the radiograph, the PA. You can see periapical lesion, history of restoration in the past, from the past. And when I saw that lesion, I automatically like to take a cone beam if I'm considering saving a tooth. I want to know um, how large the lesion is, how far does it extend, in which direction does it extend, and to give myself an idea of what I'm facing, and also when you're doing a multi-rooted tooth, how many canals should you be expecting in that tooth? Well, as a lateral incisor, this tooth only had one canal, so made it relatively simple in that regard. So I also want to start looking at the pulpal diagnosis. So we have reversible pulpitis, irreversible pulpitis, pulpitis with apical involvement, acute apical periodontitis. So these are, and then you can also have normal pulp as well. Some of the differences here, if you look at the pain of these, reversible pulpitis is usually stimulated or provoked. The others are simultaneous, so there's nothing that triggers the pain. It's just spontaneous. Radiographic findings, we can see that you're with the reversible and irreversible pulpitis. Radiographically, you may have nothing apically, but of course, with pulpitis with apical involvement, you'll see apical radiolucency. Same thing with acute apical periodontitis. The response to hot and cold, reversible pulpitis will be positive to cold. Irreversible can be hot or cold. Um, a pulpitis with apical involvement usually will be positive to heat, and acute apical periodontitis will be positive or no response at all to heat. Makes it a little bit trickier sometimes. So that's why we look at multiple things. So you look at the electronic pulp test, you'll get no response with acute apical periodontitis if you're wondering, okay, well, which one do I decide? Same thing with pulpitis with apical involvement. Whereas the reversible and irreversible pulpitis, you'll get responses when you use an EPT. So, and here, lastly, we have percussion and palpation. So with percussion, usually if you tap on the tooth, irreversible and reversible pulpitis, you won't really get much of a response. But once you get to the apical portion of things, that's where they'll usually feel it. So you'll get positive on pulpitis with apical involvement and periodontitis, and then palpation. You'll usually get some type of response on all of them. So it's usually is taking all these different key factors to make that diagnosis, because it's not just one thing. And then we look at the apical diagnosis. So we've looked at the pulpal, now we're going to look at the apical. So apically, normal apical tissues, you won't see a lesion, a symptomatic apical periodontitis. It will be painful around the apex, and it's characterized by painful percussion, just as we mentioned earlier. Asymptomatic apical periodontitis will have no symptoms. Apical radiolucency will be there, and it will be a necrotic tooth. Acute apical abscess, you have rapid swelling, you have severe pain, you have exudate pus coming out of the tooth. This is a very active infection. Chronic apical abscess, which this patient was, usually there's no discomfort, and you have a draining sinus tract. So she talked about having a bump on her gums, and that's that draining sinus tract. And the condensing osteitis is more radiopaque. So you'll have a radiopaque lesion around the tooth, and is represented by localized bony reaction to low-grade inflammatory stimulus. So we can also look at the periodontal classification to see if we did periodontal treatment around this tooth, how likely would we have of success. And so based on the classification of the periodontal status for this patient, this patient was at a stage 1. I'm just going to move forward and not go into too much detail with the classification, just to get through these cases. I know our time is limited. So in looking at the factors for restorability assessment for this patient, the ones that stood out to me the most was the amount of remaining tooth structure, as well as the existing pathology. So this is what I have in the back of my mind as I'm moving forward with this case. So what are the options? Well, usually we have an A or B situation. Either we're going to restore or we're going to remove. Pretty simple there. So if we're going to restore, what would be necessary? Root canal therapy post due to the lack of existing tooth structure, with a core and a crown coverage for protection. If we're going to remove the tooth, then we can either remove the tooth and have an implant with a crown. We can do a fixed bridge, fixed partial denture, or we can do a removable partial denture. Pretty straightforward. So what we ended up doing was I decided to keep the tooth. This is a front tooth. The patient really did not want to lose her tooth. So I told her it would be risky, but this is what we call informed consent. When someone knows exactly what could happen and they still consent to it. So we started the plan. I did the endo, and then next was going to be the post and core for this patient in order to try to save her tooth. 2 months later, she returns and she broke her tooth. This was almost anticipated in the assessment that I did with her before. So now she's more open to other therapies because yes, we could do post and core and crown still, but now you have to look at other things like the ability to have a ferrule, you know. So we're looking at other options at this point. This article by Oliveira talks about the greatest factor that influences the strength of an endodontically treated tooth was the remaining tooth structure. The preservation of all remaining sound dentin should be a primary objective in preserving the tooth strength. So we see here that with the tooth fractured, there isn't much remaining sound tooth structure, which is now pushing me into a direction of doing heroidonics, trying to be a hero, or trying to keep things very simple. So at this point, the options would now change. So we have root canal therapy, post, core, and crown. We have orthodontic extrusion because we have very little ferrule. Things are close to the gingival margin. So you could extrude, do your root canal, post, core, and crown, or you can do crown lengthening, a root canal, post, core, and crown. The removing options remain the same at this point. So what we ended up doing was to extract the tooth and plan for a future dental implant. And when I extract front teeth like this, I always give the patient an option to have a stay plate, also known as a flipper, also known as an interim removable partial denture. And so that's what we did for this patient. Dr. Uvo, I don't know if you usually take questions throughout the presentation or if I just wait to the end, how you would like me to do this. I can continue to go forward if that's what you prefer.
I think you can go forward. I don't see any questions yet, but if you have any questions, do please, or if you have any questions, you can raise your hand and we could call you to speak, or you can type it in the chat and he will address it after the second case.
Okay. So this is Taipei. I actually gave this presentation in Taipei for the first time about 2 years ago. Great place. So this is case number 2. I have 4 cases altogether. This is a 38-year-old man. His chief complaint was that his tooth chipped and it hurts when he chews. And it was on his right side. So of course we always take a pan bite wing PA to assess the situation. Took intraoral photos with the intraoral camera, so I apologize for the quality of the photos there. But you can see that there's been a large buccal cusp fracture of that tooth number 5. I go through the same process again. Let's check out the pulpal diagnosis. And on this patient, it was pulpitis with apical involvement. Symptomatic, the apical diagnosis, symptomatic apical periodontitis. And with the periodontal stage 2, based on probing depths on this patient. So this particular article, I'm bringing it up because when you have that much tooth loss, I'm trying to assess the strength of the tooth. And in this article, they consider that the stiffness of the tooth. So the article is called "The Reduction in Tooth Stiffness as a Result of Endodontic and Restorative Procedures." So once a root canal is done, how strong the remaining tooth structure um, remains is predicated upon the amount of tooth structure and where that tooth structure has been removed. So endodontic therapy, they found you would have a 5% loss in stiffness or hardness of the tooth. When you have an occlusal cavity preparation, you lose about 20% of the tooth stiffness or strength. But when you have a marginal ridge prep or marginal ridge fracture, you lose 63% of the stiffness or hardness in the tooth. So that was quite significant when I consider this particular case. This is an example of another case where we had recurrent caries. The tooth may need root canal, but you can see on tooth number 12, there's a distal amalgam that's dislodged and distal occlusal amalgam. And so the marginal ridge on the distal has been lost. And so if you were to try to restore this tooth, um, you may run into issues of the strength of the tooth, and these are all the things that you look at. So sometimes when so many factors are involved, the question is it easier to remove the tooth versus jump through the hoops to try to save a tooth? So, and the factors for this particular patient were the remaining tooth structure, the vitality of the tooth, because it was going to need endo, and the caries risk of the patient. This patient had multiple areas of caries throughout his mouth. And so how do we look at the caries risk assessment? Well, there's something called CAMBRA that looks at the bacteria in the mouth, the saliva in the diet, the saliva, the diet habits, lesions that have been repaired or arrested, and the microbial agents. So some patients can be low risk, moderate risk, high, and extremely high. This is how they classified the Canberra risk level. So based on the level of risk, the recommendation would either be an over-the-counter OTC is over-the-counter toothpaste with fluoride versus something the same thing plus fluoride rinse, xylitol, candies or gums, and an alternative regimen. And then the higher your risk goes, the more you add agents like chlorhexidine, rinses plus fluoride varnish, and even extreme risk with the extreme risk baking soda rinses. So this was developed at the University of California, San Francisco. And so here they have kind of like a decision tree based on where the lesions are on the coronal surfaces, occlusal, facial, lingual, or interproximal, or if you have something on the root surface. And so I'm not going to go into details here, but in this workflow, they talk about the cavitated and non-cavitated surfaces and how to go about approaching it. So then what are the options here? Dr. Uvo, you talked about the decision-making process. So if we're going to try to keep the tooth, we have a root canal that could be done along with post-core and crown, a root canal with a post-core bonded restoration. Many times people like to use bonded restorations. Crown lengthening, so you can get more crown structure, because if you look at the radiograph, the caries lesion is very close to the bone. And again, orthodontic extrusion plus root canal, post-core and crown. Or you could extract implant, extract fixed partial denture, extract removable partial denture. So in this case, based on the extent of the caries and the depth and the caries risk factors, all those things, the decision was made to extract and do a future implant. And sometimes keeping a situation as simple as possible is the easiest. This is a place called PP Islands, PHI, in a small country called Thailand, and one of the most beautiful destinations I think I've ever seen on these islands here. So this case number three, 80-year-old male, and he came in with a chief complaint: can you fix my smile with new crowns? You can see the how irregular those surfaces are. And when you look at the periapical and bite wings, you see a great amount of tooth wear. Um, Things are very flat and irregular. So this tells me right away that, we have a level of grinding. So in terms of the pulpal diagnosis, normal pulp. In terms of apical diagnosis, normal apical tissue. So we don't have disease there. In terms of periodontal classification, normal periodontal classification. But let's look at the photos intraorally. As you can see on the left, this is up the upper left side. This is what his occlusion looks like. Below that is when he opens his mouth, um, and protrusion of the mandible. And on the right side, you see him going into the lateral views of his teeth, and then in the middle you can see, his arches. You can see the teeth have been fractured off. Previous crowns have broken, and he still has a few remaining, but the posterior support isn't quite what it once was, and the mandibular anteriors are extremely worn. His restorations are now a little bit standing above the actual wear of the teeth. So this is what we would call attrition. So tooth wear, the etiology of tooth wear can be attrition, abrasion, erosion, and abfraction. Just to briefly go over those, attrition is when you have enamel to enamel contact wearing against each other. So two like substances or materials wearing down each other. Abrasion is when you have a non-like material wearing against something else. So if you think about like sandpaper against wood, that is abrasion. So many times in the mouth, it'll be a crown against a natural tooth. And sometimes crowns are not polished properly. And therefore, if you adjust the crown without polishing it, especially materials like zirconia, but even feldspathic porcelain, can really be abrasive against enamel. And so that causes abrasion. Erosion is when a chemical agent erodes a tooth. So if someone has GERD, gastric influx, gastric reflux, or sometimes some people suck on lemons because of the taste, and the acids from the lemon, the acid from the stomach, all these things can cause um, erosion to the teeth. And abfraction, when someone's clenching or even or bruxing to some degree, grinding, the teeth can flex. And as the teeth flex, a phenomenon called abfraction happens at the gum line. And it looks like a little bit of a, like a chiseling at the gum line of the tooth. And so that can weaken a tooth over time. So Turner in this 83 article talked about the three different categories of tooth wear, and because restoring these cases can be difficult, but to understand how difficult, he made a classification. So category one is when you have occlusal wear and you have occlusal loss of vertical loss of occlusion. Category two is when you have excessive wear without occlusal vertical loss occlusal dimension, and excessive wear without loss of occlusal vertical dimension, but limited space is your category 3. That is the most difficult, because if you have occlusal wear and you lose vertical dimension, well, it's simple just to rebuild your vertical dimension with the restorations. So if it's lost, it's easy. If you have excessive wear without occlusal dimension, but you still have space, you can keep the vertical dimension the same, and with restorations, rebuild it. But when you have excessive wear and there's no loss of vertical dimension and limited space, now, even if you wanted to regain space, it's hard to do so because nothing was lost vertically, and there's no room to do anything about it. Donovan wrote about parafunction. So bruxism, he says, is the most common form of diurnal and nocturnal uh, is the most common form of diurnal and nocturnal parafunction. And nocturnal bruxism is far more destructive because of the increased force and duration. Nobody knows when you're unconscious how long you're doing it for and how much pressure you're putting on your teeth. And the average daytime bruxism, the forces are between 150 to 175 pounds per square inch. And the average biting forces of nocturnal bruxers are between 900 to 1,000 pounds per square inch. So it's greatly magnified. So when I see teeth that have been broken down quite like this patient's, I know that's probably not just from daytime bruxing, but nocturnal bruxing. And bruxism may reduce the prognosis of a tooth because of the forces. Anything you do to that tooth will potentially fail. So if you try to do endo and you make the tooth more brittle, it will fail. You try to do crown preps and put margins on these teeth, they can easily fail, because if there's not enough ferrule or not enough restorative space, they can fail. And so one of the things that we do is make sure that they have patients like this have a hard occlusal splint, so that you can distribute the forces on a different material and not on the teeth. So the factors that would influence the restorabilities for this patient are the remaining tooth structure, the opposing dentition, and his parafunctional habits. So the questions are, if we restore, what do we do? If we remove, what do we do? So the options of restoring this case would be root canals on several of these teeth, post-core and crowns, or post-core and bonded restorations, crown lengthening again, and root canals, and or orthodontic extrusion with post-core and crowns, or and any combination of those. Or you can remove teeth, place implants, remove and do partial dentures, fixed and or removable. So the removing in this situation seems to be less complex, less complicated, but you have to be careful on when you do that. So based on this patient's generalized condition with no pain, no no disease, I didn't see caries, I didn't see periodontal issues. His teeth were just not pretty, and I know that's what he came in for, but they used to tell us in residency, ugly teeth is not a diagnosis, it's not a disease. So, be careful if you try to treat that. The fact that he's broken his natural teeth in the past, broken restorations, broken everything that has been put in front of him, it made me hesitant to try to move forward and think that I can do a better job than what was done before. So for this patient, I told him, you're not in any pain, there's no disease. my best thing that I can do for you is recommend that you do nothing at this point. Uh, they used to tell us in my training, no dentistry is the best dentistry. You only do dentistry when it's needed. And and at this point in time, I did not see anything that was needed. So I know this was a twist on this presentation, but taking on a case like this, things can get worse. People always think, well, if I place implants, if I do post and core and crowns and do, all my exotic treatment, my crown lengthening, extrusion, everything's going to get better. No, it doesn't always get better. Things can get worse. And I would rather monitor him as is than have him in provisional phases and provisional teeth are breaking, the final restorations are breaking, and and then you have to ask yourself, did I push this patient forward in their treatment, or did I in their dental health, or did I pull them backwards in their dental health? This is the fourth and final case.
Doctor, can you go back to that photograph? Sorry to drag you back. Yes, so right there. So this is you and how you think this should be managed based on obviously you have autonomy as a practitioner to look at this and make that kind of decision. If you were working for a group, the Nuvias of our world, I mean, three big names come to mind. How is this viewed? Because I know you have lived in that world before. How would this be treated? What are the options? I'm sure there are more options that you have put out.
Oh, yes, of course. So in those type of places, they would take a more aggressive approach, because as far as restoring these teeth are not a great option for this patient. So in the Nubias of the world and other groups, these teeth would all be removed. This patient would be edentulated, and then you would look at full arch implant supported prosthetics and restorations. So they would edentulate everything, remove everything, and alveoloplasty the bone, and place anywhere between 4 to 6 implants per arch, and then restore on those implants.
Okay. All right. So that is not, you wouldn't do that on a routine basis.
So cases like that, you have to understand a few things. Number one, many times it can be cost prohibitive. So in the United States, something like that may run you around $60,000, the patient, around $60,000, $30,000 for the maxilla, $30,000 for the mandible. And that will cover the surgery and the prosthetics. Everybody may not have that kind of money. That's number one. Number two, let's just say they do have the money. You have to understand what are the risks of treating a bruxer, someone who has broken everything before. Now you're going to transition them in provisional restorations. What can you expect will happen in softer materials if your enamels and your crowns and dentins have broken? So now there's a restorative complication, prosthetic complication in moving forward. And if they can break enamel, then they can break acrylic. If they can break acrylic and enamel, then they can break screws. If you can break screws, you're going to put this patient backwards. So managing the restorative can be a challenge. I'm not saying impossible, but a challenge. And so therefore, my last point is, because this can be challenging, the type of environment that you do this kind of work should be one that is prepared for handling those type of challenges.
Okay.
I started in the beginning showing the environment that I'm working in. I'm working in a community health clinic, treating community members, and it's not a high production type of facility where we manage these type of cases. When you have these type of cases, when you're doing the full mouth reconstruction on implants, it's nice to have a surgical operatory and recovery rooms and your nurses, anesthesiologists, et cetera, et cetera, et cetera, your in-house lab to help you facilitate the fabrication of the immediate provisional teeth, especially when you have fractures and those sort of things happening. The environment makes a difference. So to take a community center and bring on a case like this without having a surgeon, without having the ability to sedate the patient, without having an on-site laboratory, without having recovery rooms, without having all these facilities for the patient, it will be extremely challenging and difficult. And many times, if you do these things in the wrong environment, the patient will regret. And most times, when the patient comes out of the pocket, the way I'm describing, they're more likely to litigate if things are not exactly the way they would want them to be.
I see. Very, very good. Thank you so much. Yeah.
Mhm. So the fourth and final case, we have a 31-year-old female, and she said, at my last checkup, I was told that I might need my tooth retreated. So on the upper right-hand side, maxillary right-hand side, this patient had a root canal done. We took a panoramic radiograph, bite wing, and PA. And you can see that tooth number 3 has a little shadow around it. So the first thing I did after seeing that was took a 3D scan just to see how involved it was. And you can see from the longitudinal, cross-sectional, and the axial view exactly how deep between the roots this infection has spread. So she was talking about possibly retreating this tooth, and I told her there was absolutely no way we could save this tooth to retreat. The the damage has been done, and the problem is the root canal. If you look at the fill, the root canal does not seem to be done poorly. It looks like it was done very, very well. So if a tooth has come like this and the root canal has been done well, what are you expecting from a retreat? Do you really believe that this is going to reverse as much as advertised? I have my doubts about that. So when I see something like this, I believe it's best to uh, try to preserve as much of what you have remaining in the bone. Try to get the bone to try to heal and start fresh. So pulpal diagnosis, there is no pulp. The tooth has had a root canal. Chronic abscess, chronic apical abscess is the diagnosis here. Stage 2 period. And so basically the history of this tooth, the pathology of this tooth, and the position of the arch being a molar. These are my primary concerns, of the factors that I'm considering in assessing the restorability of this tooth. So you could retreat this tooth and do another crown, or you can extract and worry about the replacement with an implant, fixed partial denture, or removable partial denture. So the decision was made to extract the tooth and do a future implant therapy in order to give this patient a chance to heal and to have that tooth again. Because many times when you do retreats, especially in a case like this, you really don't know how this tooth is going to end up. It's really a shot in the dark, especially with a lesion that large, versus if you remove the tooth and allow the area to heal, you can go back and take a radiograph and see that, okay, healing has been done. We can do something different. So in conclusion, when I consider the restorability of a tooth, I look at the previous history, the remaining tooth structure, crown to root ratio, the vitality of a tooth, the presence or absence of pathology, the caries risk of a patient, periodontal status, adjacent dentition, opposing dentition, the position of the tooth in the arch, the function of the tooth, and the functional habits of the teeth. Again, this book kind of goes through some questions that you can in this particular chapter, evaluating restorability prior to treatment, so that you can come up with a decision-making tree for yourself. So thank you.
Right. Thank you so much, sir. We do have some questions, guys. If you have any questions, please share those questions. Doctor. Can you see the question, sir?
Can I see the questions?
Yes, Q&A. No. Okay, the first question said, Dr. Nathan, are you there? I'll ask the question, but I'll allow you to speak if you want to clarify. Is it could you have extracted and placed an immediate implant in the first case?
I'm going to go back to the first case.
Yes.
And I'll take it through to the extraction site, and I'll talk about that. So, immediate implants are an option. But if you're asking if I would do it, the answer is no. And I'll explain to you why. There are a few things. Number one, there's a lesion at the apex of that tooth. So I would be placing a sterile implant into a site that is not clean, in fact, infected. I know people say you can rinse with chlorhexidine, you can do this, you can use a curette and curette everything, as much as you can. But my question to you is, with the trabeculation of bone, can you ensure that you will remove 100% of infected tissue when you place an implant in an infected site? With the trabeculation of the bone, meaning that it's highly pitted, can you ensure that you will remove 100% of infected tissue prior to placing the implant? Number one. Number two, when you do cases like this, you have to graft. If you're going to immediately place the implant to fill in any gaps. Now the question is, if you place a graft, how long do you have to wait before you can go back in to restore the implant? Well, grafting usually takes anywhere between 4 to 6 months, and if you have any type of infection, I would lean towards 6 months. 6 months of healing before you can go back in. So if it takes 6 months of healing with the graft, putting everything at risk because you may or may not have gotten all the infection out. But let's just say you did. There's 6 months of healing before you can even go and start the impression process of restoring that implant. If I remove the tooth, within 2 to 3 months, I could actually go back in and place the implant. You remove the tooth, and I know that within 2 to 3 months, that area has healed. You take a radiograph, take a cone beam, and you look at what's there, and you can know that we're ready to go. So let's just say it takes 3 months. I wait 3 months before I go back in to place the implants. And then I usually wait 3 months after the implant is placed. That's 6 months. But the difference is I've placed an implant in healthy bone, and I've placed an implant in a position that I want it to be in. Another thing about immediate placement is you're many times as you're drilling your osteotomy, you're hitting against the socket wall and it's sliding your burr or your drill in a position that you don't want it to go, and it's hard to control that. So when you wait for the area to heal, I can now in solid bone place my drill exactly in the position that I want it to be. Let's just say I'm shooting for a screw retained position. I can more accurately do that once the bone has healed. And then if it takes me 3 months if it takes the bone 3 months to heal from the infection, 3 months to heal from the implant, what have I gained by doing immediate placement versus waiting and placing the implant afterwards? What advantage is there? There's no advantage of time. There's a risk of infecting the graft and the implant. There's risk of not placing the implant in the position that I want. I'm a prosthodontist, so the position of the implant and the restorability of the implant is most important to me. And so if I cannot restore in the position that I would like to, then that ruins the entire case for me. So I would like predictability in the position of that implant. And the best way to do so is by placing in solid bone. Was there another question? Or is there more questions on that?
There's another question that says, could a possible option for case one have been two connected crowns? I don't know what that means. Two abutments, the roots treated lateral and the canine.
Repeat that for case number one. What again?
I said, could a possible option being two connected crowns, two abutments, the root treated lateral and the canine? Thank you, Sami. Thanks for joining us. Yeah, go ahead.
I'm wondering if when they say two connected crowns, we're talking about a bridge. I'm not clear on.
I'm not sure. I mean, I would have said, I
But
thought maybe thinking about the cantilever if you take out the tooth, but you were saying it was quite specific. I don't know what, I'm not saying that that is not a common treatment to join two crowns together.
so I would like to talk about joining two crowns together. So this is a totally different topic, and that's treatment planning and treatment planning. Treatment planning. What's the word I'm looking for? Well, your protocols for treatment planning and your objectives, treatment planning objectives. And I can tell you just briefly, when I treatment plan, my objective is to make restorations that will be as long lasting as possible, make restorations that will be as hygienic as possible, make restorations that will be as retrievable as possible, make restorations that will be as biomechanically advantageous as possible. And lastly, make restorations that will be as uh, as oh, this is off the top of my head. I apologize. As individualized as possible when it comes to teeth, and why independent as possible. So why would I say to make restorations as independent as possible with teeth? Well, when you look at bridges, let's just say this was a bridge case from number 6 through 8. If you look at bridge restorations, fixed partial dentures, when you look at the literature about bridges, they'll say that the average lifespan of a bridge over 15 years is something like 85, 86%. And they looked at the mode of failure. Usually the mode of failure is either root fracture or recurrent caries. Well, many times it doesn't happen on both abutment teeth. It usually happens on one abutment tooth. So if one abutment tooth goes bad due to caries or due to root canal, due to anything, if one abutment tooth goes bad, what happens to the entire restoration? Typically, if one goes bad, the whole thing is over, meaning that you have to remove the crown from the abutment crown from the other tooth, and now you got to extract that up the tooth that may have broken, extract, et cetera, et cetera. And now you're faced with a much larger problem, whereby maybe once you started, you only had one tooth missing, but now the other abutment tooth broke, so now you have two teeth missing in that area, and now the tooth that was the other abutment that didn't fail, it needs a new crown. So when you splint teeth together and one starts to fail, you are stuck having to replace everything, whether they're two teeth next to each other or two teeth spaced out, like a bridge, replacing a missing tooth. If one fails, the whole thing needs to be replaced. Therefore, when it comes to splinting teeth, I avoid them. I avoid splitting teeth as much as I can, because of that reason. There are sometimes it's unavoidable, and this is what this topic is about, assessing the restorability and how we would restore. So if there's a better option than to do a bridge, I would do that other option. There are times when you cannot do an implant, and so your bridge becomes your only fixed option. But it becomes your fixed option knowing that here is the risk of said treatment. So if we're going to a bridge, here's the risk. So if you have a high caries risk patient, you have to be careful. You have a high uh, uh, patient with a lot of pair function, you have to be careful. You have all, that's why you're looking at everything. But in general, when it comes to splinting teeth, I don't like to splint teeth because of the risks of one going bad and having to replace two restorations versus letting the two restorations be independent, or letting the teeth be independent of each other. And if one fails, it fails on its own without dragging the other one down.
All right. Thank you. Thank you so much. I mean, those are the questions for right now. I think you gave very good answers to those.
Thank you.
Thank you guys for joining us today. We do have, let me show you this here. We do have another presentation coming up on the 29th of September. That's with Dr. Ninela Bogosian. She's going to be talking about all-on-4 concepts for full mouth rehabilitation. And also, I would share with us an opportunity here for those who are interested. We do have an implant training opportunity in Virginia on the 23rd to the 27th, where we're going to be learning implant placement. You're going to be watching live surgeries. It's 5 days. I've attended many implant programs in America. I think this is a good one. And we have opportunities of bringing people from different parts of the world, from Nigeria, from Kenya, from Ethiopia. So if you are there and you are interested and you are seeing this, I want you to send me a message. You should go to our Instagram page and do indicate so that we can, it is UVOHDE. So I know there are folks who want to attend from Nigeria. There's a little bit of a scholarship to bring in Nigerian doctors or any doctor from anywhere in Africa, from Ethiopia, from Kenya, from Rwanda, from Ghana, if you are interested in coming. So there's going to be a class in September, and there's another class in November, and there's another class in January. So please do let me know. We have 6. We can take 6 people at a time. It's a wonderful class, and you're going to like it. So if you want to, if you're interested, if you're watching and you really want to be a part of this, do let me know, and we'll tell you more about the scholarship. So go to our Instagram page and or send me a message right now. Dr. Peabody, thank you so much. Quick question: where are you traveling to next?
Heading to the Philippines in November.